Good day to everyone. I'm going to continue on my lecture about anemias and their approach in their diagnosis. This is part 2, and I am Dr. Christian Dominic Rosales. Let's start with the red cell indices as well as other parameters found in your standard complete blood count report, such as the MCV, the MCHC, MCH, the RDW, and the reticulocyte count if requested by the doctor. Alterations in red cell morphology are studied since they often point to particular causes. Morphologic characteristics providing etiologic clues would include the red cell size, as shown by the MCV, the degree of hemoglobinization, as reflected in the color of red cells, shown in the MCHC, and the shape of the RBC. The morphologic examination of RBCs is very helpful in evaluating and determining the cause of anemia. It is important that the clinical laboratorian recognize and report changes in erythrocyte morphology so that the patient can be effectively assessed and treated. The RBC indices utilize the results of the erythrocyte count, the hematocrit, and hemoglobin to calculate for 4 blood parameters. I'm going to start with the mean corpuscular volume, or the MCV. It is defined as the average volume of red cells stated in femtoliters, or FL. The formula to arrive at the MCV is this: hematocrit in percent divided by the RBC times 10. Please take note of the scientific unit used for RBC. At birth, the normal range is from 98 to 123 femtoliters. In adults, the normal range is about 80 to 100 femtoliters. The MCV is used to classify RBCs as whether normocytic, microcytic, or macrocytic, depending now on the value. If the value would range from 80 to 100, then it is considered normocytic. If it's less than 80, it is microcytic, and if it's above 100, it is considered as macrocytic. The second red cell index is the mean corpuscular hemoglobin concentration, or the MCHC. It is defined as the average concentration of hemoglobin in grams per deciliter, or percent. The formula to arrive at the MCHC is this: hemoglobin in grams per deciliter divided by the hematocrit in percent multiplied to 100. At birth, the normal range is from 30 to 36. In adults, the normal range is from 31 to 37, and it is used to classify erythrocytes as either normochromic, if the value will fall between 31 to 37, or hypochromic if it is below 31. The third red cell index is the mean corpuscular hemoglobin, or the MCH. It is defined as the weight of the hemoglobin of the average red cell in picograms. The formula to arrive at the mean corpuscular hemoglobin, or MCH, is this: hemoglobin in grams per DL divided by the RBC multiplied by 10. At birth, the normal range is from 31 to 37 picograms. In adults, the normal range is from 26 to 34 picograms. The red cell distribution with is the measurement of the variation in erythrocyte size. The standard deviation divided by the mean MCV times 100 is the formula to arrive at the red cell distribution rate. The range for normal value is from 11.5 to 14.5%. A value above 14.5 would indicate that there is a variation in red cell size above the normal amount, and this is considered as anisocytosis. If the value is below 11.5, it would mean that the RBC population is more uniform in size than normal. The reticulocyte count is a parameter used to determine the quantity of reticulocytes in the blood. The number of reticulocytes is a measure of the regeneration or production of RBCs. It appears as a polychromatophilic RBCs in a typical right stained blood film. You have to remember that reticulocytes are young erythrocytes that have matured enough to have lost their nuclei but not their cytoplasmic RNA. Recognition of reticulocyte is done by staining a peripheral blood smear with a new methylene blue to help visualize remaining ribosomes and endoplasmic reticulum. At birth, the normal range is about 1.8 to 8%, and the normal range in adult is from 0.5 to 1.5%. A reticulocyte count above this range, also called as reticulocytosis, is a clinical indication that the body is attempting to meet an increased need for RBCs. An increase in reticulocyte is observed when RBCs are being hemolyzed or destroyed in the bloodstream. As an anemia gets more severe or intense, younger cells that take longer than a day to mature are thrown out into the peripheral blood, and these are the shift reticulocytes. Now let's define the terms anisocytosis and poikilocytosis, and they are helpful in certain types of anemia. Let's compare the two terms. Anisocytosis is a state wherein the patient's red blood cells are of varying or unequal size, and we report the degree of anisocytosis as slight, moderate, or marked, depending now on the number of abnormal forms noted. Meanwhile, poikilocytosis is defined as an increased variation in the shape of RBCs. It is considered normal to have some variation in shape, but some shapes are characteristic of a hematologic disorder or even a form of malignancy or cancer. Here is an illustration showcasing size variation, hemoglobin distribution, shape variation, inclusions, and red cell distribution affecting RBCs. I'm going to discuss each one of them as we progress in this particular virtual lecture. Poikilocytes are numerous, and I'm going to discuss each one of them in the succeeding slides. I'm going to start with the terms elliptocyte and ovalocyte. Such terms refer to RBCs having an oval or egg shape, with varying degrees of elliptical shaping from slightly oval to almost a cylindrical form. Sickle cell or drepanocytes are RBCs that typically appear as narrow and shaped like a sickle with two pointed ends. Target cell, also called as podocyte or leptocyte, are RBCs having a peripheral ring of hemoglobin, an area of pallor or clearing, and then a central area of hemoglobin. Spherocytes are RBCs that are not biconcave. They appear as round or spherical because of the loss of a portion of the cell membrane. And spherocytes are small cells when they are seen in the peripheral blood smear. Stomatocytes are RBCs having a central pallor on the blood film. Schistocytes, also called as fragmented cell or helmet cells, are fragmented or irregularly contracted red cells with markedly jagged outlines. Moving on, teardrop cell, also called as dacryocytes, are pear-shaped or teardrop-shaped RBCs having an elongated point or tail at one end. The Burr cell or the crenated cell, also called as echinocytes, are erythrocytes with scallop, spicular, or spiny projections regularly distributed around the cell membrane. A similar looking cell, the acanthocyte, also called as a spur cell, are red cells having spiny projections that are irregularly distributed around the red cell membrane. Now let's proceed to the red blood cell inclusions, starting with the basophilic stipplings. Basophilic stipplings are dark blue granules evenly distributed throughout the RBC, resulting from precipitation of ribosomes and RNA. And basophilic stipplings are found in conditions such as thalassemia minor, megaloblastic anemia, and lead poisoning. Siderocytes, also called as Pappenheimer bodies, are small, dense, blue-purple granules of free iron and combined with hemoglobin, seen better with a specific stain for iron, such as the Prussian blue. When siderocytes or siderosomes are right stained, they are sometimes called as Pappenheimer bodies. Howell-Jolly bodies are round, densely staining purple granules that are remnants of the RBC nucleus and thus are deoxyribonucleic acid. Howell-Jolly bodies they are often seen in the peripheral blood after removal of the spleen, as well as in cases of abnormal RBC formation. Cabot rings are rare, thread-like, red-violet strands that are found in ring, twisted, or figure-of-8 shapes in reticulocytes due to the abnormal RBC formation during mitosis. Parasites can also invade RBCs, and an example of a parasitic organism is the malaria. Heinz body are denatured hemoglobin precipitates noted after vital staining with a methyl violet or crystal violet. There are also irregular or abnormal RBC distribution patterns found in the peripheral blood smear, and this would include the Rouleau formation and agglutination. Rouleau formation is a arrangement of RBCs wherein they appear like they're stuck together or become aligned in aggregates that look like stacks of coins. Meanwhile, agglutination is exemplified by an irregular or amorphous clumping of RBCs in the blood film. Rouleau formation is associated with elevated plasma fibrinogen or globulin. On the other hand, agglutination can be caused by the presence of a cold agglutinin or antibody in the patient's serum. Now let's proceed to the classification of anemia based on the morphologic appearance. There are four common groups in the anemic classification. They can either be macrocytic, normocytic normochromic, simple microcytic, or microcytic hypochromic. Here's a table showing to you conditions which fall under the three labels or tags, under microcytic hypochromic, normocytic normochromic, and for the macrocytic forms. Examples of microcytic hypochromic anemia would include conditions such as iron deficiency, thalassemia, anemia of chronic disease in some cases, lead poisoning, and sideroblastic anemia in some cases. Conditions which show a normocytic normochromic type of anemia would include some cases of anemia of chronic disease after an acute blood loss, disorders affecting the kidney, mixed deficiencies, and bone marrow failure, such as in post-chemotherapy or invasion by cancer. For the macrocytic type of anemia, conditions such as megaloblastic, vitamin B12 or folate deficiency anemia is an example, and in non-megaloblastic forms such as in states like alcoholism, liver disease, and in myelodysplasia. That's all for part 2. Please proceed to part 3. Till then, thanks for watching.